Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Vita Health. We would like to remind you that the Q&A feature will be available, so feel free to send in your questions for our speakers. And with that, I will turn it over to our moderator who joins us from Forbes, Alex Knapp.
Oh, good afternoon, everyone. Very excited to be moderating this webinar on the question of whether virtual care has revived the future of disease management. And I hope by the end of the hour, you've got a good sense of what the answer to that question is. And we've got a great panel, and also looking forward to taking your questions about virtual care, about disease management, and what the future of the technology looks like. But first, let's go ahead and introduce our panelists. And love to start with you, Richard, if you could tell us who you are and what your background is in this field.
Hello to everybody. It's good to be with you today. Thank you, Alex, for moderating the session, and to my co-panelists. I'm Richard Frank. I'm a physician. I'm the Senior Vice President of Medical Affairs at Vita Health, primarily focused on payer strategy for both the clinical and go-to-market perspectives. Long history in managed care besides being a physician, spent the bulk of my career at some national payers as the Chief Medical Officer for Medicare and Medicaid, and then also worked on the startup world for such companies as Aspire and MyNexus. And it's good to be with you all.
Great. And Harlan, why don't you tell us a little bit about your background here?
Well, hello to everybody, and thank you for including me. I am a physician as well. I'm the president of strategy and business ventures at City of Hope and NCI Comprehensive Cancer Center. I'm also the chairman of the board of Access Hope, which is our spinout company that is focused on bringing NCI level care to the patient and doctors so they can get their care in the community. My background is also in population health. I've been the chief clinical officer at places like Optum and oversaw clinical operations at Anthem prior to coming to City of Hope. Thank you for having me today.
Great, thank you, Harlan. And last but certainly not least, Linda, would you please introduce yourself?
Thank you. Hello, everybody, and thank you, Alex, for being our moderator. I'm a physician also. I am a psychiatrist by training. Most of my background, early background, is in graduate medical education and teaching. Then I transferred into quality improvement, and most recently have been involved as a former medical director in Medicare for the Central Region of the United States for Anthem. And I am currently deeply involved in a collaborative care disease management project with a large physician group in the Michigan area.
Great, thank you so much, Linda. And I'd love to kick things off by just looking at big picture, this topic of virtual care and disease management. And Richard, I know the history actually goes back quite a long way, and wanted to get your thoughts a little bit on that history and how it was maybe a decade or so ago and how that's changed today.
And I won't assume, Alex, that you're giving me the question because I have the most gray hair on the webinar. I won't make any inferences from that.
I'm pretty close too. It's hard to tell,
but disease management, I think, sort of appeared in the 90s. The whole vision was that if you manage a population of individuals, patients with a particular disease state, educate them, enable them, encourage them, those patients will then make the right choices in the management of their disease to improve clinical outcomes. And there was a whole industry in the 2000s built around this. And then Medicare did a number of demonstration projects throughout that period of time, focused on single diseases, focused on care coordination, care management. And late in the early 2000s, like 2010 through 2012, it put out a blistering analysis of roughly 34 different demonstration projects, and not a one of them really drove a positive return on investment. There were variations in performance, and we'll probably talk about why there were variations during the course of the webinar, but it decimated the industry, basically killed off disease management in one fell swoop. And it wasn't really until kind of about 5 or 10 years later, sort of the mid-teens to more recently, that disease management was resurrected. And I think in part because of some of the learnings of those early demonstration projects, in part because of technology, and in part because of smartphones. And so I think we're in a new era of disease management. I think it's different than what we saw before.
Great, and really like to get into that, the technology aspect. And I think a part of that is, around that time when that report came out, we were also undergoing a lot of changes in the healthcare system because of the Affordable Care Act. One of the things that was also happening at the time was a requirement to move to EHRs. And Linda, I know that this is a topic you know about. How did that technology, the data, how has that changed how disease management is working right now?
It became a tool that helped us begin to focus both on populations of patients as well as individual patients. As you know, I took a number of hospitals live on Cerner, one of the EHR platforms, and the transition to that let us implement more evidence-based care, but it also let us implement better coordination, better communication between specialists, nurses, some of it synchronous, some of it not synchronous or asynchronous. But as a tool, it helped us stratify and target populations, helped us communicate better across the whole spectrum of care.
And Harlan, kind of piggybacking on that, in terms of the technology and the care from this perspective, what things do you see as really improving disease management? What are you kind of looking forward to?
Yeah, I think the technology enables us to reimagine the way we define disease management. If you go back to Richard's comments about the industry in the 90s, that was the second generation. There was an initial generation before that started with the pharma industry, which was creating their own disease management programs that were specific to getting people to be more adherent to medication. And then the industry grew, and really, the way that Richard was defining it, it really started in the 90s and grew in the 90s. But here's how I would think about the use of technology going forward. In the 90s, the concept was the delivery system is failing to do this, and that this industry was going to come in and work in parallel to the delivery system and sort of prop it up, but they never really interconnected. In fact, I would argue that 98% of doctors during the 90s couldn't even define what disease management was, and they certainly never heard of the companies like that were prominent at the time, like American Healthways and Core Solutions and things like that. So as I think about your question about technology, I think one of the things it can do is solve that fundamental problem, which was disease management was working in parallel with the delivery system, and there was no interaction. And you can see why. It was very hard back then. Nothing was electronic. But now you have physicians that are wired to their electronic medical record, and you have ability to have communication between a disease management entity and the provider. And I think it's really important that we try to highlight that, because I would make the argument, as long as they're working in parallel, we're always going to sub-optimize it. And the real opportunity of disease management is to figure out how to coordinate and integrate with the delivery system, as opposed to going in with the attitude that the system itself is failing. We should be working in synergy and recognizing that disease management can just, quite frankly, do things at scale that even integrated practices can't do.
I would add to that we've really transitioned from disease management to care management or chronic condition management. I think it's also important to know that we're now looking at the patient as a whole, as opposed to a specific disease, which you kind of get the impression of when you use the term disease management. And the other thing I would add, going along with what Harlan said, systems like our systems had been operating in parallel, in part because our physicians, our nurses, no one had been trained to use the new technology until recently. That has many pros, it has a few cons, but many pros that we're now training people to be able to use the electronic record, to be able to communicate with each other, to be able to have virtual teleconferences. And all of that training had to occur also.
There's another aspect of the technology that I think was a learning that came out of the demonstration project earlier in the 2000s. Those companies that had better outcomes, not necessarily the idealized outcomes, but better outcomes, were those that interacted directly with the patients in some type of human interaction. And in the 2000s, really the only way you could do that was by telephone or to be in person. Telephone still is impersonal, and many of us will ignore any phone number we don't recognize. And in person isn't particularly scalable. So what technology, smartphones have now allowed us to do is to have a human contact through a video conference like we're doing here today. And so this kind of human interaction, I think, was one of the key takeaways from the demonstration project for organizations that hope to produce impactful outcomes. There has to be a human being on the other end of the engagement. It can't just be a letter or instructions on how to modify your diet.
And it looks like we got a question from the audience here from Christine. She's got two questions, one about the main differentiator between then and now, which I feel like we've kind of answered in the course of just chatting here. But she has an insightful question, I think, about, isn't the success of complex care and disease management best served by influencing patients with influence behavior change, getting patients to buy in and change their behaviors and change their practices to be a part of caring for the disease. How big a part of care management is that?
Yeah, go ahead, Linda. You're the psychiatrist, please.
Behavior change is very difficult, but very important. Medication adherence is what we are aiming for as one of the key elements of disease management or chronic care management. But again, the way that we make it work is through finding out what's important to the patient. That's why motivational interviewing, for example, works. Find out what's important to the patient, and that's what we focus on in terms of changing behavior. Go ahead, Richard.
I was going to say that I think Christine in part answers her first question with her second question. One of the great takeaways from the 2000s was behavior change. If you simply, the belief in the 2000s, the 90s was simply, if you educate patients to make the right choices, they'll simply make them. And the answer was that's not true. You need to solve for social barriers to care. You need to solve for cognitive dissonance. You need to solve for depression and anxiety. And I think the most successful disease management companies, or really any intervention which is focused around behavior modification, has to incorporate behavioral health as an associated strategy to manage the high incidence of depression and anxiety that you see in patients with chronic disease.
Yeah, I think that's the key element. And the way I frame it is there's a personalization aspect that really didn't exist 20 years ago. And quite frankly, it was too expensive. But I think it's important, as people in the audience think about what do they want to invest in. There's always that tendency to want to invest in efficiency. And I remember the quote, best companies of the 90s were the ones that were the most homogenous and it had the greatest efficiency. And it didn't matter who you spoke to, but you had call center mechanics and and technology to speed to answer the phone as quickly as possible. But I think what we've learned, and you've heard Richard and Linda talk about, is you can rack up great metrics of contacts, but it's really the quality of the contact that matters. And to have a high quality contact, we're beginning to recognize that people are different, diseases are different, and you need to be able to personalize. And that's what technology allows you to do. And quite frankly, if you think about what scale looks like in disease management, it's not really just more people for greater efficiency and queue management. I would argue it's about the ability to better match that coach and that technology solution with the individual. Again, something that the doctor remains absolutely, and the nurse in the practice remain absolutely important, absolutely central, but they can't be all things to all people, and they can't do it between meetings. And now you can create a complementary solution that can personalize and tailor the solution to what that person is actually ready for, what they want. I would also point out that we talked about diabetes as being diabetes. Well, let me tell you something. Your reaction to diabetes is quite different when you're told that you're pre-diabetic and you need to lose weight, as opposed to when you're told you're insulin-dependent diabetic. And then your diabetes frame of mind changes again with that first time you have angina or the first time you pass out from hypoglycemia. And you need to have a program that is actually sensitive enough to where that patient is, taking into account depression, anxiety, and I was really impressed by cognitive dissonance. Big words, but the point is these are all important. And you really have to meet the patient where they are. And that is what I think we can do better through technology than we were able to do 20 years ago. There just isn't enough time to have to tease out all this information, and people's comfort with technology allows them to self-populate information that allows you to understand what's really important to them.
You know, that the point that you both made about the impact of behavior and depression and anxiety on chronic conditions, how people react to it, how they manage the condition, it's really brought home when you look at, for example, in a large Medicare population, and you look at the fact that 25 to 30% of the highest risk, highest cost patients also have a diagnosis of depression or anxiety, and it may not have been addressed until you have the tools to look at the population and then to look at each individual in terms of how that is affecting their care.
You know, that's an interesting point. And one thing that I'm curious about, I mean, obviously anxiety and depression seem like they would go hand in hand, you know, knowing that you're dealing with a chronic illness. But even if they don't, or they're, you know, not something that kind of lingers for a while, I'm sitting here thinking about the last 2 years of the pandemic when people around in March were, you know, being very good about their masks and their distancing and things like that. And at this point, you know, even in places where you still need to mask up, like airports and stuff, I mean, the adherence is not so great because I think people are just kind of tired of it. How can technology, how can care teams, how can you manage folks who maybe have to manage their care for, you know, a long time or even the rest of their life? How do you make sure they don't get tired and just sick of having to deal with it?
Well, they do get tired of it. They do get tired of it. It gets back to, though, what Richard said and Harlan echoed, that personal interaction. One of the things that the pandemic taught us is that it's tough when you're alone and things don't go well when you're alone. If you have a partner, if you're alone and you don't want to be alone, if you have a partner who's helping you, someone on the healthcare team, for example, or even a friend who is helping you look at your disease in terms of the information you get from your wearable or information you get from talking with your doctor virtually, being able to access a nurse, for example, after hours, being able to access your therapist after hours. It lets you feel less alone, and it helps to motivate you to continue to manage your chronic disease.
I'd like to build on what Linda just said. And I think as you think about the future of, we call it disease management, but I agree it's really managing chronic illness. And quite frankly, there's a convergence between that distinct disease management industry and care services. And we can maybe talk about that during the hour as well. But you know, the opportunity and the challenge is to reinvent disease management in a way that's not focused on how do you build the best business, but really focused on how do you deliver the greatest value to the patient or to the person, and then create the right solution that becomes a business around that. And what I mean by that is, we talked about, I absolutely agree, you want multimodality access to therapists, to to a psychiatrist, to your doctor, to a nurse when you need it. But loneliness is a huge issue, particularly in the elderly. And maybe we can leverage this to think more about connecting to communities and move. Disease management never really went into group visits or building communities. And now, sort of the non-healthcare industry has led the charge in building communities. This is a great opportunity because, we're all scared of, well, what if they get bad information clinically? You know what? Most people will deal with bad information. There's plenty of that out there. What they really want is connectivity. And if you really want to get at the root of depression and anxiety, loneliness is a big part of it. So, we need to reinvent or reimagine how we define disease management and not feel so regulated by, standard or traditional health values. I also don't think we should be restricted in definition and try to apply what we do for diabetes to another emerging chronic illness in my area, which is cancer. And when we were designing our cancer solution, and we didn't call it disease management, but it falls into this category, we literally got in a room and said, Harlan, stop thinking like a health plan, because that's what my experience was when we started this. And others, stop thinking like an academic center. Think like a cancer patient and figure out how do you wrap around services to help that cancer patient. And I'm not going to go through, what was weeks of planning, but essentially, you're a cancer patient. In addition to having the fight of your life and being terrified, you have to figure out between 3 specialists, second opinions. You don't really want to go in necessarily to meet with a nutritionist every time. You don't want to meet with behavioral health or mental health support in person every time and pay for parking. Can you create a wraparound experience and call that chronic care management, and not have it be like that one-off, nurse to patient on a phone telling you to be adherent to drugs? There's so much more to the journey than just taking your medication in cancer. So you have to be specific to the individual and specific to the condition to make sure you're really meeting their needs.
And I really want to capitalize on something that Harlan said in addressing your question, Alex, about burnout to managing chronic disease. My guess is 20 years ago, nobody ever imagined getting a notification from their phone that says, you've been using me too long today, you should turn me off. So the whole idea of using technology to create a wraparound experience that Harlan talks about, creating a greater social engagement, gamifying the experience of managing something chronic. So the technology, to your earlier question, really can allow us to create a disease management solution that actually encourages patients to want to do this through reward systems, group chat, through engagement with your coach, through behavioral health solutions. All of that can keep the patient engaged.
Go
ahead, Linda.
No, I can't agree with you more. I do want to also address something that Harlan said about looking beyond the traditional structures of providing health when you're talking about chronic disease management. We really do need to go into community settings more for example, because sometimes, and one of the questions has to do with what happens, what do you do if a person doesn't have access to a smartphone or a smart device? Well, but they probably have access to something else in their community where they could engage in interaction with others, with other healthcare providers virtually, perhaps there. So I think we do have to integrate more of what we're doing in community settings where people actually are. The best diabetes care management in my community was done in Twilligers, which is a biker bar that has a deer pole out back. And there was nurse information there. There were other people with diabetes talking with each other. We just have to expand our minds a little bit. And also they could refer virtually to the specialist who is online.
You know, I think we need to figure out a way to make the good parts of chronic disease management work and become part of the norm. And it still feels like it's outside the system. And I think there's an opportunity here to actually help educate the physician practice. And I feel comfortable saying that because, you know, you have 3 physicians on the panel here. But, you know, I remember I was 15 years into my career when I stopped asking myself, how come my patients were always so compliant and everyone else has this problem? And, you know, you just realize that we're not aware of all these other psychosocial needs of the patient and non-compliance or non-adherence, to use the term of art. And it's not because we're ill-intended. It's just we have so many other things going on. Our training doesn't focus on it. And particularly if you've been out for a while, it just wasn't part of the medical curriculum. So I think there's an opportunity that if people in the audience are really like become the ambassadors of this message, we need to get this concept infiltrated, permeated into the delivery system. And when you do that, then you start to address the question, well, it doesn't have to be through a smartphone, because now you have your physician thinking about this, and your physician can say, do you know that your employer or your health plan has these programs? And when you get the endorsement of your doctor, your adoption of these programs goes way up. And then you can figure out whether some people will actually start to use the smartphone because they find out it's not that hard. But otherwise, people will just get more engaged with a nurse or a therapist or a community. And I think you'll see that the paradigm of how you deliver chronic care management will change, because doctors will start to change. Right now, doctors are still, unless you're part of an integrated group taking risk, you're just not focused on what happens outside your room. And I think there's a way that we can normalize this and really change the way all healthcare is delivered. We just have to aspire to do that.
It's interesting that the whole term social determinants of health is now being talked about out loud, when we all knew in the back of our minds that there were various social determinants that might affect someone's use of medication or access to it. And so we're now training, finally, more of our providers to recognize these social determinants of health.
And I think part of it is that the doctors appropriately, fairly feel helpless to correct these issues. And I think we should think about these disease management programs as actually support for the practice, to give the doctors somewhere to turn for things that they can't do on their own. Again, it's that complementary working with the delivery system that's key. And I'll give you an example. I was asked somewhere between 10 and 15 years ago to talk at the ADA. And this is right at a time where new drugs were coming out. And I started, and I'm not a diabetes expert, so no one's going to be listening to me. So I started the talk, and I gave a case study of a diabetic patient. You know, you got them to stop smoking. They lost 10 of the 20 pounds they needed to lose, but their A1C was still high, and new drugs had just came out. So I said, they're failing on their sulfonylurea drug. What do you go to next? And there was a raging debate between metformin and glitazone back at that point, raging debate. And I just said, you know something, I don't know the answer to that question, but I do know that 2/3 of your patients aren't taking the first drug that you thought they were. And your next step ought to be to get them to actually take the medication. That mindset is just not out there. And if we can get disease management and the technology and telehealth involved to help support with adherence to behavior change, weight loss and exercise, but also just drug adherence, we can really enhance the delivery of care and make life easier for the physician. But we just have to integrate it as opposed to making it more work for the doctor or something that's not trusted by the patient or the doctor.
And the doctor can't do it alone. The doctor can't do it alone. We have to pull in other resources to help people be more adherent. You're right about that. I think part of our problem was feeling like we had to be the end all and be all, and we can't do it alone. We need the team. We need to pull in resources from the environment to help people be more adherent.
One thing that is kind of interesting in terms of getting doctors to integrate this into their care, and I'm pulling some themes from several of the questions here from the audience and trying to stream it down. And I think for part of the reason, 10, 20 years ago, part of the challenge was there weren't enough technical tools available for doctors to have. I would say we're almost faced with the opposite direction, where when I go to ask a doctor, because I got pitched a startup that's got a new app, they're usually curse under their breath that now there's another one they have to learn about. How can we make technical integration into practice? How do we make that easier for doctors? Is it, can we use AI? Can we use automation? Is there a way that we can kind of let the doctor worry about patients and not worry so much about which app he needs loaded on his tablet and what? And I'm sure all three of you know, every time I talk to a doctor, the biggest complaint they have about their work is having to spend a bunch of hours at the end of the day filling out their EHRs. Like, what role is there for technology to itself, whether it's through automation or AI or whatever, integrate and make this easier on providers?
I think when those of us who've had operational roles will remember the mnemonic people, process, technology, there's a reason why it's in that order. So the idea that you're starting with people in systems who have a workflow process in place, and the idea is that technology is intended to reduce the friction of those processes. It's not intended to drive, or ideally it's not intended to drive new processes or new approaches. It's intended to create efficiencies. So while there certainly are instances where technology can wholesale change the way work is done and create new value and new opportunity that didn't previously exist, when I think about physicians in their offices meeting patients with even today, the idea is a primary care physician is seeing 6 patients an hour for 8 hours, roughly 50 patients in a day at 10 minutes a clip. Ideally, what technology is doing is smoothing the workflow. And so as we think about how disease management functions, how the technology supporting disease management functions, how it should integrate with electronic health records and integrate into physician workflow and really other provider workflows as well, the idea is the people designing the technology have to be working closely with the people who are working day to day to understand what their workflow is. You cannot design this technology and these app-driven approaches in isolation from what's happening day to day in caring for patients. So that to me is how technology can support what the physician is doing.
Yeah, I can't emphasize what Richard said enough. I mean, if you don't solve the workflow issue, you're going to get an allergic response, which Alex is probably what you're getting. I mean, it could be the way you asked the question too, by the way. You may want to think about
that. Could be.
but I think, when you talk to physicians, they all have different opinions and they all have different workflows, which is part of the problem. But the consistent themes are the information has to be accurate. It has to be pushed to them at the point of care. And it has to be meaningful, impactful. And, if you don't satisfy all three from the beginning, so it's not a race to how many gaps in care you can present to the doctor. That's where we were at in the 2000s. But in the 2000s, when I was talking to a doctor about how I can improve my gap in care tool, they basically said, why don't you pre-shred the information before it gets to me? So
that's the best I have heard.
That's
what I'm
good.
taking away from this webinar is pre-shred it.
I got it. I like it.
Yeah, I hope that's not the quote that it gets my name attributed to it from the webinar. But but the point is, you have to again recognize, what's important to that doctor-patient relationship if that's the point that you're intervening. And I think you need to you need to be able to have a hierarchy of needs and recognize that just throwing 15 things at the doctor is not going to help them, and you need to use either AI or ML. And again, what Richard said is fundamental. It has to be done in collaboration with what the delivery system wants it for their practice. But I would also add, we should be talking to patients and figure out what they want, like what would improve their interaction with their clinician at the point of care. And then separately, what do they want in terms of support? And that's what Linda and Richard were talking about, which is that personalization of, whether it's multimodality or multiple options for products, let them pick the one that's going to, motivate them, because everyone does get tired, and you need to have something that's interesting to the patient. And then hopefully they get healthy and they become consumers. And with consumers, we have no problem changing up what we offer folks. So let's not put people on a plan and a solution that's going to be a 5-year plan when we know we have data to show that the drop-off happens after 3 to 6 months. So let's not pretend that we don't need to modify and enhance the experience over time.
Right. And I think there's a really key point about transitioning this, as Harlan did, back to the patient, because when you think about something like managing diabetes and you have a patient whose sugars are consistently out of range, there's absolutely the requirement that the physician, the diabetic educator, the nutritionist who's in the physician's office are educating the patient around best-in-class management of their diet, exercise, and glucose management. But the reality is how one consumes food, how one moves about during the day, how one manages their sugars, that's a day-to-day experience and really requires somebody who can use the kind of clinical information that can come from continuous glucose monitors, glucometers, et cetera, to work with the patient as a coach about how they're going to modify their lifestyle over time, not over a 10-minute visit in a physician's office, but over days to weeks and potentially to months. And so the idea that there is a program that is aligned with the physician, that is aligned with the care system, that can sit above it and work directly with the patient on modifying their lifestyle, and encourage them to do so and reward them for doing so and make it an exciting or at least interesting activity. That's a critical add-on to what we see in physicians' offices. So I think it's, as much as we need to integrate with physicians in disease management, I don't think there's any world where a physician has the time during their day to talk about pairing blood sugars both before and after a meal to see what happens with the patient's blood sugar. I think you need to layer on incremental services to solve for those challenges.
I couldn't agree with you more. As an example, I worked in a system that decided to put a small clinic in a supermarket. And then the system had certain patients go to that supermarket to shop. The coach actually went around with the patient, buying the food, helped the patient develop diets for that day, that week, that month. Yes, the patient had to know how to test their sugar and so on and so forth. But the problem was what the patient was buying to eat and what they could afford to eat. And so that part came into it also. So you're right. It's a bigger issue than the patient learning a particular technology.
And on a you have an interesting question from Vicky in the audience, which, how do we make it easier for providers with programs and tools provided by their health plan, where, you know, one health plan might be partnered with a couple of different apps to help with disease care, but then other health plans are using different apps. How do we make it easier for doctors to keep track and to make sure that they're working with the tools that are available to the patient through their insurances, through Medicare, whatever they're using?
So the reality is that falls to the health plans. That's really, I think the health plans are obligated to think about how to make things as seamless as possible for the physician's office. Most health plans try to create a standardized approach to managing their members and share that information through their network representatives with physicians' offices. There are contractual arrangements, certainly between large physician groups and health plans, around taking risk, being accountable for outcomes, as Harlan mentioned earlier. And in establishing those kinds of relationships, there is market power for the providers to demand certain types of interfaces between the plan and the provider so that it's as seamless as possible. But the reality is, in the United States, we have a multi-payer marketplace, for good or for ill. And the reality is, even if you have a dominant player in one particular line of business, like Medicare or Medicaid, you may not have it in commercial, you may not have it in the exchange business. And then there are still those patients who come in with limited or no insurance whatsoever. So there's no doubt that it's a challenge to try and create a seamless experience. I also think it sits on the vendor or the provider of the various programs that we're talking about, whether they're disease management, musculoskeletal care management, et cetera, to similarly create a seamless experience for the physician as much as possible and create an ecosystem that's easy to navigate.
But from a business point of view, we need to also think about what would be the motivation for a vendor to make their app interoperable with another if they're trying to push their app in the marketplace.
Yeah, I think to some extent it gets back to the whole reframing of the healthcare solution. I know we have to be realistic and practical. We're not going to blow up the system and reinvent it. But so first of all, I wouldn't leave the patient out of it. I think there are things that when you sign up for your health plan or through your employer, you should be aware of these programs and actually go in and advocate for yourself to have your physician learn more about the program and interact with the program. So that's, one thing is how to communicate with the patient and empower them to seek out these own solutions. But, in the world today, doctors have to figure out how to bill differently for each health plan and for Medicare and Medicaid. They have to figure out how to, coordinate with different referral networks for their specialists when they refer. So I don't think it's beyond the realm of possibilities that if the practice cared enough about this, that they could figure out, how to, find the right program. Because again, to the points that you just heard from Richard and Linda, the health plan and others need to make it easier and make it electronic, but you also just need to establish the expectation that the practice inform their front office staff, and they need to push this information and make it really easy for the doctor to know which programs are available. We put vital signs on the chart. We put BMI on the chart. I know practices that put insurance status on the chart. I don't know why you can't put for a diabetic, what programs are offered through the employer on the chart. It's changing the mindset, which is why I keep making the point that we can't have this be an independent industry. Particularly when there's that bridge of telehealth that really does connect the traditional delivery system to what are these remote care management or chronic condition management programs. We really need to think of them as an integrated system and not as separate components. So I think it just takes a mind shift. And I'm thinking about the audience here. I think if you're sitting there in the audience, you're an employer or a health plan, this is immediately applicable and you understand, what potential role you could play. But I would argue that anyone listening to the webinar involved in health should take an active role in trying to reimagine the way we deliver health, particularly to our most vulnerable people. I mean, the people who are in underserved communities or statistically minorities have less support for chronic conditions and in some cases higher risk. The same is true in cancer, by the way. African-American men die at twice the rate of their white counterparts for prostate cancer. African-American women die at 40% higher rate for breast cancer than their white counterparts. I mean, there are huge disparities. So I would argue if you're anywhere sitting in the ecosystem of health, you should be out there advocating for redesigning the healthcare system. And I believe what we're talking about here, although we haven't mentioned specific solutions, where the general concept of supporting people on their mental health and their anxiety and depression, supporting people with loneliness, supporting people with education, recognizing these are chronic illnesses that exist between office visits. I mean, how can you not advocate for that? So what I would say is let's raise our expectations with our health plans and our employers and say, we want more of this and we want it baked in, and we expect, for those of you that are on the provider side or do direct provider contracting, we expect people to stand up and better integrate these programs into their practice and advocate for them with their patients so patients can benefit not just from the interaction with the doctor, but from the whole ecosystem.
So I'd love to follow up on that, Harlan, and again, pull in some themes from a couple different questions in our audience. When we talk about scaling up managed care, especially for these underserved communities, they often face double or even triple whammies where the technology, a lot of rural communities don't have access to high-speed internet. You have communities that have shortages of healthcare workers. In a country that has a shortage of healthcare providers generally, I think Mark brought up there's a shortage of endocrinologists, which we need to deal with diabetes. So when we have manpower shortages and we have technology shortfalls, what are ways that we can still kind of integrate these models and still move forward to serve these communities, despite the obstacles?
So the first thing I would say about that is that disease management, scalable tech-enabled disease management, while it does face all the challenges that you just articulated, in a prior day, they wouldn't even have been available. So we can solve for some of the challenges in populations that don't have access to high-speed internet, rural populations. And in fact, some of the best disease management programs can function off of a cell phone with standard 3G or 4G internet connectivity. You don't need to have high-speed desktop internet access in order to solve for these issues. Having said that, there will always be a role for, at least for the foreseeable future, I suspect, a role for phone-enabled disease management. I think that phone-enabled disease management is definitely better than sending a letter saying this is what you should do. That was one of the learnings that we took away from the early 2000s, but it's not nearly as valuable as a webinar-enabled or a face-to-face conference like we're having today. I think many of us prior to the pandemic would have bridge calls and never look at the person you're speaking with. And that was the default. And now the default is every single meeting that I have, even with people I don't know, has, I hate to list various vendors, but Teams or Skype or FaceTime or Zoom that we're using today. So there's no doubt that these challenges exist and persist and will continue, but scalable disease management has solved for more of those gaps than the technology we had in earlier days.
And Linda, I want to address this to you, and this is another question for the audience, is there also some psychological resistance on the part of patients to kind of use this technology or deal with this, or even just, talk to the doctor in the first place to get started taking care of themselves? And, if so, how can we help patients get more comfortable with using technology and for, taking that stronger role in their own care?
I hate to say this, but it goes back to individual contact, what we've been talking about it, personalizing it. I do want to perhaps correct some thoughts that people have, that people who are elderly hate technology or don't want to use technology. You know what? It depends on the person, number one. And number two, as Richard was saying, and we all know, 75–80% of people in this country have cell phones. They may or may not be the most sophisticated cell phone, but more and more people are able to use cell phones for many different things, and with the right encouragement from a trusted person, perhaps their physician, perhaps somebody who works in their physician's office, or perhaps a healthcare worker that's in their church, for example, can encourage them to use something as basic as their cell phone to communicate with their doctor, to read texts from their doctor, to check on their blood pressure. It doesn't necessarily have to be the most sophisticated technology to be effective. I think it's the primarily the phone, or the phone and a device at home that made it possible for us to help some people get their blood pressure under control. Text messages, that was pretty much it. With congestive failure, it's the scale, and using the phone doesn't have to be the most high tech, but you do usually have to have a person to partner with the individual to help them make that step.
Yeah, I think the themes that you just heard are really important. So first of all, I'm all about customer and patient, customer segmentation and patient stratification. But these are personal interactions, and sometimes the best thing to do is just ask, like, what do people want? Because recognize it will change over time. It'll change by circumstance. I don't want to misquote, but I think it was a Kaiser study, but regardless, it was a study on telehealth, and more than 2/3 of the population preferred telephone over video. And it's because it was routine, urgent care issues. They didn't want to have to worry about what they were wearing or the background of their house in the room. And you just have to meet that need. Now, on the other hand, if you're taking care of someone with heart failure and you have the advantage of a camera, and you can say, can I take a quick peek of your cabinet? And you see all this processed food. Think about how inefficient it is. You go in your doctor, you tell them I keep a great diet. I don't add any salt to my food. They're not lying. They just don't, people don't understand where the salt comes from. Think how much wasted energy you have in the healthcare interaction when you don't really understand what's going on with your patient. So, I think there's a tremendous opportunity to picking up on, Richard's point about how this can actually lead to greater efficiency and greater abundance of resource. If we question our norms, like, does a behavioral health interaction need to be 50 minutes? Probably not. Do you need to drive in to get your blood test? No, there's probably a local lab. And then you can, free up capacity of the doctor's office, but also have a very meaningful interaction with a doctor or someone else in the office for normal results. So I think technology gives us more flexibility to do more with what we have from a resource point of view, but also bridge those gaps in those areas that have, access issues or greater challenges in accessing specialty care. I think we're just at the very early stages of figuring out what video telehealth can do in addition to the chronic management. And I would suspect we're going to have a whole new model of chronic condition management in 5 to 10 years, and we're going to have new roles. I mean, I don't think you have to be a traditional nurse or LVN to go into a home and do some of the work that Linda was talking about. I think we're going to have new healthcare roles that are part of a broader ecosystem, but we have to advocate for it. I mean, left to our own devices, we will do what's good for what we have today. And if you look at the variability in outcomes and disparities in healthcare, the number of diabetics who are truly controlled for cholesterol, weight, blood pressure, and A1C, I mean, the results today are abysmal. We have to do something differently. And I don't, we're so risk adverse. But that being risk averse makes sense when you're starting in a great position. I would argue we're leaving so much on the table. And the same is true in cancer. I'm not a cancer expert, and I've learned a lot in the last 9 years. But boy, this pandemic taught us you can deliver a lot of great care and support to cancer patients remotely without making them travel great distances to wait in a room in a waiting area, which is uncomfortable for them. You just have to be, willing to invest and reimagine the way healthcare should be delivered, and then push your stakeholders to aspire higher.
Right. I think on that we're running very, very close to the end of our time. So I do want to thank all of the panelists for their time, for their thoughtful answers. I want to thank everyone in the audience for their engaging questions. And with that, I think we've got less than a minute to go. So let's not risk keeping anyone longer. Thank you all so very, very much. I appreciate it. And thank you, Richard, Linda, and Harlan.
Thank you, Alex.
Thank you.
And thank you to the audience.
Thank you to Alex and all of our speakers. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, November 13th through 16th for Health 2022.